So friends, now we have Dr. Harshmukh Balar, very well-known hemato-oncologist of Surat city. He is from Blood and Cancer Institute, Solaris, Sathwagat. He has done MBBS from GMC, Vadodara, MD from Government Medical College, Surat, Hematology, Sayadri Hospital, Pune. His area of interest are leukemia, lymphoma, multiple myeloma, thalassemia, sickle cell anemia, bone marrow failure, bone marrow transplant. His achievements are he has achieved gold medal in hematology and bone marrow transplantation. He has established comprehensive hematology and bone marrow transplantation center in Surat, and he is first to do bone marrow transplantation in Surat and whole South Gujarat. He has done more than 125 bone marrow transplantations till date. So we welcome you, Dr. Ashwin Bhai. You can start your talk. Time given to you is 20 minutes.
Good evening all. First of all, I would like to thank the organizing committee for such a wonderful academic event. And thankful for that. Today, I will talk on leukocytosis unrevealing. So basically, it is a very common problem. In any branch, any department, we can find the leukocytosis in day-to-day practice. So it is a very common, still alarming sign. So whenever you see the WBC count high, there is something in the going in background. So I will discuss in my first slides. We will cover the cases and then little bit about the leukocytosis. So what is the definition? Leukocytosis is the broad term for elevated WBC. Anything more than 11,000 WBC we can call leukocytosis. So we will start with the case 1. These cases are real, but I kept this value is hypothetically to make it better understand. So 45-year male, asymptomatic, clinical examination nothing, on routine checkup, hemoglobin was 12, WBC was 18,000, and you can see 81% neutrophil, and platelet was 5.58. So what will you advise? Next investigation, what do you think? Anyone?
Bone marrow.
No. So next it would be the peripheral smear examination. That is very important test. So many times we jump. That's why I kept this thing. So we will always jump to the bone marrow, flow cytometry, BCR-ABL, JAK2, NGS panel. But we forgot our basic test, peripheral smear examination. You can see there is a beautiful picture of peripheral smear examination. All type of neutrophil are seen from immature to mature neutrophil. So now, next investigation, there is a neutrophilia from blast to mature neutrophil. So it will be BCR-ABL. So I was suspecting chronic myeloid leukemia. So I have encountered many cases, many doctors, if they see the WBC count is high, they are directly sent to the flow cytometry. I have seen the report. So there is no role of flow cytometry in this case. So this is a BCR-ABL report. Is it visible? Sorry. So it is a positive. And diagnosis chronic myeloid leukemia. You don't need to do bone marrow at all. So this is a diagnosis from peripheral smear examination. Thus one simple test BCR-ABL that will cost 4,000 only. And treatment will start. Imatinib. That is a 2,000 rupees per one cost treatment. So patient is OPD based treatment, nothing to do. No need to admission, nothing. Second case, same parameters are same, just you can see the reversal of ratio. Lymphocyte is 80%, first it was a neutrophil. So we have to see the CBC properly. Either neutrophil is high, lymphocyte is high, monocyte, eosinophil, anything, we have to see it properly. So again, next investigation is peripheral smear examination. And now you can see there is a lymphocyte, mature looking monotonous lymphocyte. So it could not be the chronic myeloid leukemia. So what will test you will offer here? So it is a flow cytometry. Same case, same value, but investigation differ. Again, you don't need to do the bone marrow. And peripheral smear examination, on peripheral smear you do the bone marrow, and that you will find this, I'm sorry, that graph is not visible, but there is a marker for the CLL. So it was a case of chronic lymphocytic leukemia. Third case, 18-year girl, fever since 1 week, mild sting, palpable, and values are same again, but there is 80% monocyte. So again, Sam, what are these cells? These are the lymphocyte, but looks like monocyte. So 18-year female with mild splenomegaly, 1 week of fever. What will be your clinical diagnosis? What will you think? So again, I will send the EBV. It was I am suspecting infectious mononucleosis. 18-year female fever, lymphocytosis with it was that cell we call mononucleoid cells, mononucleosis. That's why the terms infectious mononucleosis came. So EBV titer was high and the diagnosis was infectious mononucleosis. So based on age, our differential diagnosis may differ. Case number 4, 40-year male, complaint of itching all over the body and same value with the eosinophil is 81%. So there is a beautiful eosinophil on peripheral smear examination. Next investigation, there is NGS panel and there is a PDGFR positive. So diagnosis was chronic eosinophilic leukemia. So there is no bone marrow at all in all these cases. Case number 5, 45 male, known case of diabetes, presented with fever, admitted in ICU with hypotension. On routine investigation, you will find 81% neutrophilia, but there is a mild borderline thrombocytopenia. That is only different. So again, there is a peripheral smear examination, neutrophilia with toxic granule. So what will you advise? What will be next investigation? It must be over infective etiology. So CFPI, PCPI and blood culture shows GND. So it was a case of leukocyte reactions. So again same value but different diagnosis. So now we will start with the leukocyte. So we all know there are two types of leukocyte, granulocyte and agranulocyte. Granulocyte, polymorphs, eosinophil and basophil, and agranulocyte, lymphocyte and monocyte. So whenever you see the leukocytosis, you have to think these 4 codes. You will remember these 4. Infection, inflammation, malignancy and iatrogenic. Iatrogenic, you should think about steroid, lithium, beta agonist and GCSF. So you first differential your mind what is the thing behind. So type of leukocyte based on their biological significance. Either it is physiological or pathological. In physiological, it could be functional or protective and adaptive. So physiological cause of leukocytosis are newborn infant, food intake, exercise, pregnancy and sun exposure. That will lead to the physiological cause of IWBC. Based on mechanism of leukocytosis, increase the mobilization from bone marrow pool, stimulation of leukopoiesis, that is a true leukocytosis, mobilization from marginal pool in vessel and hemoconcentration, there is a false leukocytosis. So causes of stimulation of hematopoiesis by infection caused by bacteria, fungi, virus, inflammatory process like burns, MI, allergy, vasculitis and myeloproliferative neoplasm. Causes of increased mobilization of leukocyte from the marginal pool in the vessel, we can call demargination, like use of medicine, epinephrine, glucocorticoids, non-steroidal inflammatory drugs, psychological and physical stress, hereditary deficient of adhesive molecule on the surface of the leukocyte. So there are causes of leukocytosis. We have divided neutrophilia, lymphocytosis, monocytosis, eosinophil, basophilia and blast. One of them will present. Neutrophilia is the most common type of leukocytosis. It's defined as an increase of absolute neutrophil count more than 7,700. There are 2 types basically, primary neutrophilia and secondary. Secondary is a reactive neutrophilia, can respond to wide variety of stimuli. Primary, due to the abnormal increase in neutrophil production by the bone marrow due to impaired neutrophil production regulation. So either benign or malignant. What is the difference? So in the benign cases, most of time WBC count less than 50,000, predominantly mature, toxic, there are presence of toxic granule and thrombocytosis. In malignant cases, always more than 50,000, pronounced shift to the left. There is a presence of dysplasia and blast. There are 2 pictures of benign and malignant. So these are the causes of neutrophilia. First is perforated tumor in infection. Second is GCSF related. Third is chronic myeloid leukemia. Then CMML. Then myeloid neoplasm with eosinophilia. So all are the differential diagnosis of neutrophilia. Secondary neutrophilia is a commonest cause. Secondary neutrophilia, many times, most of cases are secondary neutrophilia. So mostly WBC range of 11,000 to 2,500, and patients are more concerned nowadays. If you see the WBC count 18,000, they will ask you, what is the cause of my WBC high? Why? Is it I have a malignancy or not? So then you have to search for these causes: physical or emotional stress, vigorous exercise, temperature changes, seizure activity, cigarette smoking, surgery, even obesity. Many of cases are mainly obese patients will have a normal WBC count in the range of 15 to 30,000. Hyposplemia, asthenia, or generalized bone marrow stimulation like hemolysis and blood loss. In sickle cell thalassemia, there is a neutrophilia. So these are the most common cause, and first we have to rule out this cause before asking the other test. Next is monocytosis. Again, benign and malignant. In benign, there is a transient and there is history of some drug and infection. In malignant, it is a persistent monomorphic monocytosis, and there is a presence of cytopenia and dysplasia. So there is two different picture of the benign and malignant cases. Lymphocytosis, again benign, usually pleomorphic. You can see in the smear, it is a pleomorphic, second one. And in malignant case, it is usually monotonous. So whenever you see the lymphoid leukocytosis, these are the differential diagnoses. First, I already discussed infectious mononucleosis. In case of massive myeloma, you can find a high TLC leukocytosis, reactive CLL, pro-lymphocytic CLL, splenic marginal zone lymphoma, other lymphomas, blastic mantle cell lymphoma, LPL, and various lymphomas. You can find the lymphocytosis. This is the important. Malignancy, that is the rare, but this is the common thing. So, what are the causes of reactive lymphocytosis? Most of the time in viral infection like dengue, you find a lymphopenia. But few viruses like EBV, CMV, HSV, influenza, adenohepatitis, Coxsackie, HIV, and dengue, few cases of dengue, we will find a lymphocytosis. Other are bacterial infection like tuberculosis, syphilis, brucellosis, typhus, and pertussis. You can find the lymphocytosis rather than neutrophilia. Other rare toxoplasma, BBCO, drug sensitivity, autoimmune disease, vaccination, cytokine, smoking, stress, endocrine disorder, and secondary to malignancy. Eosinophilia, if it is a benign, then it is transient, there is history of drugs, infection or allergy. So in history, you should rule out most of the time you will find some form of the allergy or a parasitic infection in this case. Malignant, it will be persistent, immature cell present, and there is a presence of cytopenia and dysplasia. Again, basophilia, benign is very rare, you will not find basophilic leukocytosis. Mostly, if you find a basophilia, then it is a malignancy under that. And last of this leukocytosis is blast. So if there is a blast, there is a various type of leukemia like ALL, AML, APML. These are the cases of blast and lymphocytosis. Steroids. I will emphasize this slide little bit. We all know this molecule, but there are dual effect of steroid on neutrophil count, on the leukocyte count. It may cause leukocytosis. You have seen your routine practice, if you are giving in in RA or any other autoimmune condition, there is a increase in WBC count, 12,000, 20,000, even 50,000 also. But if patient has underlying lymphoma, leukemia or myeloma, then it is an anti-leukemic effect. So in this case, we should avoid the steroid before proper diagnosis. Otherwise, once we give a steroid, leukemia, lymphoma will get in remission and will not diagnose in the time. It will difficulty in diagnosis. And again, it is last account, they are resistant to our steroid and other chemotherapy drug. And steroid receiving patients, survival is not good. So before proper diagnosis, exact diagnosis, we should avoid the steroid in all cases of neutrophilia. So this is my last slide. Leukocytosis, confirm the CBC and differential manual blood smear. You have differential increase of blast. Then there is a one neuro and ancillary technique of cytogenetic flow cytometry. There is a myeloid, you have divided in monocytosis, neutrophilia, and basophilia. If there is monocytosis, we should do the EBV test. If it is a fever, patient present neutrophilia and fever, then we should rule out the infective cause. Without fever, we should diagnose the CML and other leukemias. And if there is eosinophilia, again, you have to rule out the allergic, parasitic and drug history. And then if there is a no allergy, parasitic or drug history, then there is a battery of tests for eosinophilia. Eosinophilia is a vast topic, and you need starting from bone marrow to NGS panel. In lymphocytosis, again there are two causes, reactive. Most of time on peripheral smear you can figure out whether it is reactive or malignant. If it is malignant, you should do the flow cytometry. Next day you will get the result whether it is CLL or most common cause of malignant lymphocytosis is CLL. So in this peripheral blood flow cytometry will get the result. We don't do the bone marrow. So many times CLL patients don't require treatment. That's why. And again, last, if we don't find a proper diagnosis, we need to do the bone marrow and other tests. So, take home message for my this presentation: rule out the reactive cause of leukocytosis by history and clinical examination. That is the most important thing. Peripheral smear examination is the most important investigation. Appropriate use of ancillary technique reduce the financial burden and help to arrive early diagnosis. Like if WBC high, you can't randomly send the BCR-ABL or flow cytometry or NGS panel. You have to see the slide and then you have to decide I should go for the flow, BCR-ABL, NGS, bone marrow or nothing like viral marker. Avoid steroid unless life-saving till the arrival diagnosis. So whenever you see the case of leukocytosis, you have to think on these 4 points. This is our team. I am thankful for them. This is my clinical staff and team. Thank you.
Thanks. Yes, exactly. Any questions?
Yeah, I would like to have a few questions. That's why I keep my presentation short.
Right. Yeah, you have still time.
Yeah.
Anything from the audience?
So in dengue fever, platelet count is very much on the lower side.
Yeah.
What to do?
So basically in dengue there is immune thrombocytopenia, pathophysiology is immune. There are no standard guidelines, but in our routine practice what we do, if there is no bleeding, patient is asymptomatic, not toxic to, we don't give a transfusion. Irrespective of platelet count, if it is 2000, don't give a platelet. It will not helpful. Platelet will not rise. You have seen it. If you give a one whole STP in dengue, platelet will not increase. So there is no role of giving a platelet transfusion, and it will increase the risk of transfusion related reactions. But if patient has high spiking fever, toxic loop, ascites, hemo concentration, and platelet is less than or any sign of bleeding, and platelet is less than 10,000, then considering the platelet transfusion, whatever it helps. Routinely we don't give.
Is there any drug which can elevate the platelet count?
There are few drugs. Most common is like steroid, first and foremost. But we avoid to give a steroid in the viremia phase, like day 5, day 6. Steroid will increase the chances of viral replication. So patient may have a worsen. So after 5 to 6 days, patient is stable. Don't give a steroid. It will increase by itself. But we have a few parameters like ferritin, LDS, fibrinogen. We routinely do that. If ferritin is so high, LDS is high, fibrinogen is very low, then there is a, we can say, secondary macrophage activation, HLH. Patient is developing HLH and there is a role of steroid. That time we will give a low dose steroid, I can say 8 mg BD to PDS. That is a low dose dexamethasone for few days, 3 to 4 days only. Otherwise, you should avoid it.
Sir, I have had acute premyeloid leukemia in 2009.
Okay.
Is there any chance of a relapse?
Relapse APML in 2009.
Yes.
Patient is still alive.
I am talking with you.
Oh. No. So, in our definition of relapse, 5 years. If patient relapse within 5 years, then it is a, we can say it is a relapse. After 5 years, it is new disease. So, no relapse. And even APML, we don't observe a relapse. Very few cases. And that time we think about the diagnosis. We miss some mutation other than APML at that time of diagnosis. So APML don't relapse, routinely don't relapse, not relapse.
Sir, for eosinophilia you mentioned allergy and drugs. Which are the common allergic drugs?
Allergic drugs.
Allergy and drugs for eosinophilia.
Eosinophilia, yeah. Allergy, any form of allergy can cause eosinophilia like asthma, parasitic infection, skin allergy, eczema, and many, not many drugs, but any drugs that leads to the allergy. So, if patient develop hypersensitivity to any drug, it can be paracetamol. So, if patient develop the reaction to that molecule, that will lead to the eosinophilia. It is a mechanism, but not particularly one drug. Any drug can cause eosinophilia.
Atrazine can help in eosinophilia.
If there is underlying allergic infection. We routinely, what in my protocol, if I find a patient with eosinophilia in stable, we have to think stable, there is no cardiac involvement. If it is cardiac involvement, without any investigation or this passing a time, we have to give a steroid. Otherwise, we will not survive. If there is patient is stable, we give atrazine, anti-allergen for 2 to 3 weeks. If there is an infective or inflammatory, then eosinophilia will come down. If it is not come down, then we will go for the test. Because eosinophilia, it is not simple diagnosis. It starts from allergy, inflammation, hypereosinophilic syndrome to the leukemia. And it is most difficult to diagnose, to label. One marrow may not help, then you do cytogenetic may not help, you have to do NGS. There are so many things for eosinophilia diagnosis, and it is a costly. So we will do 2 to 3, we will not do anything. We'll just give atrazine and either cytogenetic or anti-allergic.
Thank you, Dr. Hasmukh Balan. Word leukocytosis explained us a lot. Really an unrevealing lecture you gave to us. Afterwards, I just want to appreciate Dr. Dubasia, sir, for being so active. And at this age also, your mind works so sharply, keeping us all behind. Thank you so much for interactions.
Thank you so much.
I would like to call Dr. C.K. Patel and Dr. B.U. Joshi to offer memento to the speaker.